Thank you so much to you both for joining today. You know, Dr. Hoadley, I'd love to start with you in understanding the progress of Medicare in the nearly 60 years since it's been around. I mean, when it was created, nearly half of Americans 65 and older were uninsured, and more than half paid for health care out of pocket. So, you know, nearly 60 years later, where do we stand?
Well, it's really one of our big successes in the healthcare sphere. I mean, as you point out, you know, back before there was Medicare, a lot of people really were struggling to find how to get care. They didn't have coverage, and without coverage, you don't have access to services. And now, you know, it's not perfect, but Medicare really does guarantee that nearly everybody who's over 65, as well as those with disabilities and certain other conditions, have access to health insurance that really does provide them access to the care they need.
Mm-hmm. And, you know, Dr. McClellan, you're the former CMS administrator. How have the needs of Medicare demographics evolved? I mean, in 2022, what should the agency be focused on?
Well, you heard a lot about that from Chiquita just in the last session. So this is, I totally agree with Jack, this is an extremely important program, not only for some of the most vulnerable Americans with the greatest and most complex health needs, but also it's now big enough with our, you said, our shift in demographics. So many people covered by Medicare and Medicaid that has an impact on our overall healthcare system, so it shapes what happens everywhere else. And with the changes that have come, with people living longer, with more biomedical progress, you've talked about that all morning, Medicare's benefits and Medicaid benefits do have a challenge in keeping up. I was there at CMS when we implemented a prescription drug benefit. That was passed in legislation in 2003, you know, decades after drug coverage was part of many other insurance programs. And it's something that Congress is still thinking about now, because we need to make sure that it keeps up to date with the changes in medical technology, which are now moving more in the direction of more complex biologic products, specialized treatments like gene and cell therapies, early diagnostic technologies, and these were not the way that medicine was practiced back in 1965. That was about treating an illness and treating a problem with a body part or an illness after it's progressed in the hospital. Now, and for the future, it is increasingly about identifying people at risk early and intervening with treatments that can intercept, if not cure, the progression of an illness early. And that's a redo for the way Medicare is set up, and I don't think we're all the way there on keeping up with that.
Right. And Dr. Hoadley, to that point on Congress, I mean, where does the discussion on this currently stand in Congress when it comes to prescription drug coverage? I mean, I'm on the campaign trail quite a bit. I hear a lot of congressional candidates talking a bit about this, and it seems like that's something there's a bipartisan push for. I mean, what can we expect to see?
Well, there is, you know, this is an important area, and as Mark says, the drug benefit in Medicare is relatively new, but it has some issues that have arisen. So one of those is the fact that there's no out-of-pocket limit. That's something where there's bipartisan agreement that there ought to be an out-of-pocket limit. So if you happen to be taking one of these very costly drugs, you reach what's in Part D world called the catastrophic phase. Now, in most healthcare worlds, catastrophic coverage means you stop paying out of pocket. In Medicare, you don't. And so there's a proposal as part of the current legislative package to cap out-of-pocket costs and set an absolute limit. And while both parties may not agree on exactly how to get there, they do agree on that principle. There's other parts that there's more disagreement on, which is how do you tackle the pricing of these very important new drugs? And we have drugs now that cost tens of thousands of dollars, if not hundreds of thousands of dollars for a year's use. And you know, part of the discussion, at least in the Democratic proposal that's before Congress, is how to start the process of having some greater government role in negotiating the prices of those drugs. And so maybe that will emerge from this year's package and the reconciliation bill, maybe it won't. But trying to figure out how we get a handle on drug pricing is really one of the challenges that we have.
Right, right. And I mean, I just want to make a note before we continue. Karen Jones, who is the president and CEO of the National Caucus and Center on Black Aging, unfortunately couldn't be here with us today, but I would love to chat with you both about, sort of what we were going to chat with her about as well. I mean, she focuses on how this is impacting the Black community in general. I mean, Mark, I'll start with you. How is this impacting minority communities in terms of, the prescription drug benefits?
Well, those out-of-pocket costs for seniors and people with disabilities with high healthcare needs unquestionably is having a big impact on access for seniors. And when we designed the benefit in 2004, it was a different era. There weren't as many of these specialized drugs. We weren't even sure if drug coverage would actually work. And so what we ended up with was a benefit that didn't provide very broad coverage or an out-of-pocket limit at the high end, and one where the government is actually picking up 80% of the cost of those drugs. Now, that's not a good recipe for either protecting seniors or encouraging strong negotiation to keep costs down. And Jack's right that there are some differences of opinion about how exactly the Medicare drug benefit should be modified, but I think there is actually fairly strong, at least by today's standard, bipartisan support for modernizing it to include an out-of-pocket limit, to shift more of the accountability for costs in that high end of the benefit, and also in what's left of the so-called donut hole or coverage gap, shift more of that to health plans who should be on the hook for negotiating lower prices, and to drug companies to some extent too. So that piece of the legislation I think would be really helpful for people like those with limited incomes who are struggling with drug costs today. The others, I think, more controversial. I think there are probably better ways to try to bring prices down. The negotiation, such as it's called, provisions in the legislation now are not an approach that any other country on the planet is taking to try to negotiate prices. Those efforts really do try to focus on value and are we getting the drugs that make the most difference to the people who need them. This is really setting a regulated price that would be kind of lower for Medicare than everybody else. So that's not good for price negotiation in the ACA exchange plans or the commercial plans that also are really important to people with limited means today.
Right, but there is, hope for the future, I mean, with the legislation. I mean, I guess I'm curious, coming from the political side of this, how much is that politics hindering this? Because it seems to be a bipartisan issue, but when you get into the nuts and bolts, and I'll pose this to both of you, I mean, it seems like that's where some of the issues lie.
Yeah, it is. I mean, and this is where, the nature of the way debates have evolved in Washington has changed, because when I first came to Washington a long time ago, there was a lot more there would be the big debates that were partisan and were disagreements over, some of the higher level issues. But the Congress would sit down and figure out the more technical things that there was agreement on, and you get those done. So right now we're in a situation where the parts of prescription drug reform in Medicare, and of course I could take this to other issues as well, but that's the one we're on at the moment. There's a big set of issues on which there's bipartisan agreement. There have been, the last Congress, the previous 2 years, there was an agreement among, I think on the Senate side, on a package that, agreed across parties. But it fell down because there was a different version in the House and they never could get to the agreement. We don't see the process of sitting down and figuring out a way to carve out the things that they do agree on, get those passed, continue to have the debate, and maybe somebody prevails on the more controversial things. But we don't get those other things done. And we're talking here about drug issues. There are issues with the broader part of Medicare. You asked the question about minority beneficiaries. Another big barrier to those with limited resources is the lack of an out-of-pocket limit on Medicare as a whole. So we have some very large cost sharing in the Medicare program, not the way we would probably design a program today. We have 20% coinsurance for any kind of physician services. We have a very large first day deductible when you have a hospital stay. People solve that if they're low income by being on Medicaid. Some people solve it by going to a Medicare Advantage plan, others by supplemental coverage. But we still have a small segment of the population who has none of those. and faces those high out-of-pocket costs. So again, we could redesign, I think probably without a lot of partisan controversy, the core Medicare benefit to make it suit the needs of people better. But of course, that would then run into bigger level debates about other parts of Medicare in which there's not agreement. But if we could really focus in on some of those things where there is agreement across party lines, we could probably make this benefit a more modern benefit that suits the needs of today rather than the way it was designed in the 1960s.
Yeah, it made me think back to when we were passing the Medicare Modernization Act, and that involved discussions with, I was in the Bush administration at the time, so obviously a lot of Republicans, but also Senator Max Baucus, Senator Ted Kennedy ended up not supporting the full bill in the end, but was very helpful in getting to crafting a package that could work, and less of that is happening now. Instead, I think you're seeing more of that happen, especially for vulnerable and underserved populations in the states, where there is a lot of interesting work going on around trying to integrate Medicare and Medicaid benefits better. So for the lowest income beneficiaries, they do get more comprehensive help with Medicare costs and Medicaid wrapping around, but often those programs are fragmented, and you get the results like you heard about from Chiquita, where we're just not delivering integrated care to patients that could prevent everything from maternal health problems to people being able to live at home and do better with their serious chronic illnesses or Alzheimer's disease. And then you also see steps like this happen, and that's by the way happening in blue and red and purple states. It's not as partisan. And you also see that happening in the efforts that the administration is undertaking using its regulatory or administrative authorities, like, as Chiquita alluded to as well, the ACO REACH program, which is really an effort to channel more resources and more intentionality into actually helping the providers for people who typically have less access to care put together the kinds of services that those individuals really need to navigate in the healthcare system and stay well. It's incredibly hard today for people with middle-class resources. It's even harder for people with health problems and worried about where their next meal is coming from or housing problems. But there are good examples of how to address that, and I really want to commend the administration for trying to take that on in the absence of more comprehensive legislative solutions.
Right, and I want to go back to your point about what's happening in the states. So you're saying that a more federal action versus the patchwork of what you see happening at the states would be more effective?
Well, it is a patchwork at the state level, and to Jack's point, if there were steps, some good ideas out there with bipartisan support for how you can make it easier to integrate Medicare and Medicaid benefits or to update the Medicare benefit package. If you think about some of the technologies that have been discussed today, Medicare benefits just don't do it.
Right.
It takes an act of Congress to cover a preventive service. So what are we going to do with all of these, multi-cancer detection tests that are coming along and all these other genomic or proteomic-based tests that can really help identify patients who are at risk? And Medicare is very good at covering the downstream problems, but has been less good at providing coverage for the social determinants, the social factors that have such a big influence on whether people are able to take their medications. It's not good enough to just provide drug coverage and low out-of-pocket costs for drugs if you can't focus on how am I going to adhere to my medication this week because of housing issues or threats at home or other things like that. And as Chiquita said, there are a lot of good examples coming from states and coming from local initiatives supported by things like the Medicare ACO program to try to address this, but they're not as systematic as they could be. And that's where it seems like there is some potential for more bipartisan action. Everybody, I think, fundamentally agrees that healthcare should be increasingly about accountability for getting results for patients, for actually improving health, and I hope we can find ways to get there.
Right, and I'm curious, just as a layperson, someone who doesn't work in the field of healthcare at all, we're year 2 of this pandemic. How has COVID-19 impacted Medicare, or has it had not as big of an impact because I guess they're not directly linked, or maybe they are? I'll pose that to both of you.
Well, if you don't mind, this
Yeah.
is when my first talk with my CMS staff when I became administrator was telling them, you were the nation's largest public health agency.
Yeah.
And I got pulled aside by my staff after saying, you're not at FDA anymore. It's the FDA before. This is under not under the
Yeah.
Public Health Service Act. This is under the Social Security Act. It's about paying for health care. But how we pay is so important. And if you look at what's happened in the pandemic, it's been disastrous in so many respects. Slow access to testing, and even when we had tests and treatments available, really uneven and inequitable access, especially early on, leading to big health disparities. But if you look at the things that CMS did in the previous administration and this one, rapid introduction of lots of flexibilities in how to pay for care, new steps to provide additional payments to physicians and labs that were quickly diagnosing patients and sharing that information to help with local response and to help those patients get better outcomes. And under these, back to the boring topic of alternative payments, these alternative payment models, those primary care groups and health systems didn't have that big trough in their payments. They had stability in payments, so they were able to build on the steps they're already taking around home-based care and telehealth and services like that. I think when we look back historically, we're going to see that the steps that CMS took were probably pretty fundamental to our healthcare system being able to adapt and move out into the community and take more steps to help contain the pandemic. All of that said, we still have a long way to go,
Right.
and I don't think we've yet learned the lessons from COVID, either on the public health side or what it should mean for the way that we pay for drugs, pay for vaccines, deliver health care.
Right, and Dr. Hoadley, would love to get your take on that.
Yeah, I agree with what Mark's talking about. I would bring up another area that's maybe not got such a happy story, which is our nursing homes. And I think COVID really helped to shine a light on some of the shortcomings of what's happening in our nursing homes. They weren't very quick on their feet to adapt. Even things like getting vaccines out, there were ultimately some good ideas out there about how to make sure people in the nursing homes got their vaccines, and it was partnering with some of the drugstore chains to get them out there in the nursing homes. But I did some interviews at the time, and it worked some places and it didn't work so well other places. And of course, there was the overall issue of reluctance to vaccinate in so much of the population that affected staffs in the nursing homes. And so we had that sort of going on. That's probably not something you can put on the Medicare program for blame. But Medicare is one of the funders, along with Medicaid, of most care that's in nursing homes. And so, I think there's room to try to go in and learn, what were the mistakes made, what were the successes, and how do we do a better job of maintaining care in nursing homes. It's not one of the areas we do well, whether we're talking about skilled nursing that comes after you have a hospital stay, or more of the long-term care for people who just can't live in their homes anymore. So I think that's an area where there's a potential for some examination and trying to see how we can do better in the future. Not just for a COVID-type situation, but more generally.
Absolutely, absolutely. And we only have 30 seconds left or so, so I think we'll leave it there. Thank you so much to you both for joining me today. It's been such an informative discussion, and a discussion, we'll be having on the campaign trail going forward. So thank you so much, Dr. McClellan and Dr. Hoadley. Thank you.
Thanks.